Welcome to the Adult Obesity Guidelines webinar series hosted by the Office of Lifelong Learning at the University of Alberta and Obesity Canada. My name is Denise Campbell-Scherer. I'm the Associate Dean for the Office of Lifelong Learning, as well as a family physician here at the University of Alberta. It was my great pleasure to serve on the executive of the Canadian Clinical Practice Guidelines. The new clinical practice guidelines are expansive, 19 chapters on a wide range of topics related to obesity diagnosis and management, weight bias, and more, all written by Canada's top researchers, health practitioners, and patient advisors. They're the first truly patient-centered clinical practice guidelines on obesity and the results of more than 3 years of hard work. We're really thrilled and overwhelmed by the interest and stimulating discussion for this series. Given the scope of the pharmacotherapy session, we've decided to provide a separate session on bariatric surgery. We'll send the invitation for the live event to everyone registered for this series, with recordings sent after the event as usual. I encourage everyone to join the Timed Right group to participate in the active dialogue going on between sessions. Just before we begin, I'd like to go over a few items. We acknowledge that we are on the traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. Webinar housekeeping. If you have questions pertaining to technical difficulties, L3 or Obesity Canada programs and services, please use the chat feature of the webinar. The chat box is located in the middle of the black bar on the bottom of your screen. If you have a question for our panelists, please use the Q&A feature of the webinar, also located on the black bar at the bottom of your screen. Our panelists will answer several questions following the oral presentation. Some questions will be responded to through text in the Q&A window. You can, at any point, use the Q&A button at the bottom of your screen to submit questions. We anticipate many questions. Please review what's already been asked and upvote those questions you'd really like to see answered. We cannot guarantee the panelists will be able to respond to all of your questions. A recording of the webinar will be available next week. It will be sent via email to all of those that registered. This link is for your personal use and is not to be forwarded or shared. This activity has not been formally reviewed by the CFPC or Royal College. However, it is eligible for non-certified credit. MainPro Plus participants may also earn additional certified credits by completing a linking learn to practice exercise. Please contribute your experience with obesity management to inform our advocacy and programming. So while you're waiting or after the event, or after you see your next patient, please take 5 minutes to contribute your perspective. We're working to try to build a national overview of the current state of affairs going on with obesity management. So it is my very great pleasure to present Dr. Sue Pedersen, who will be sharing with us about pharmacotherapy and obesity management. Dr. Sue Pedersen is a specialist in endocrinology and metabolism and a diplomate of the American Board of Obesity Medicine. She has a busy practice at the C-Endo Diabetes and Endocrinology Clinic in Calgary, Alberta. Dr. Pedersen is involved extensively in clinical research for obesity and diabetes. Furthermore, she's the lead author on the pharmacotherapy chapter on the 2020 Canadian Obesity Guidelines and a member of the expert committee for the 2018 Diabetes Canada Guidelines. Dr. Pedersen has become a leading voice on how to treat obesity and educate healthcare professionals globally. She has a public information website about weight management and diabetes at www.drsue.ca. So Sue, I'm going to turn it over to you to present your guideline chapter.
Wonderful. Thank you so much, Denise, and thank you very much to everyone who is joining us for this symposium and seminar. These are my disclosures. It's really a pleasure and honor to be able to present the pharmacotherapy chapter of the Canadian Obesity Guidelines in the next 35 minutes or so. We'll have the formal part of the presentation, and then we'll open up and have lots of time for a good discussion. In the previous sessions over the last 4 weeks, there have been lots and lots of questions about pharmacotherapy, so we want to make sure that we've got a good amount of time to address those questions. The guidelines have been a labor of love. I think all of us as authors can agree over the last 3 years or so, and it's really wonderful to have the chance now to share the learnings from our literature review and to present our suggested approach to obesity management in Canada, and today with our focus on pharmacotherapy. So the things that we'll go through in the next half hour or so. First, I'll just describe the rationale for pharmacotherapy, the methodology behind the literature review for our chapter. We'll talk about the pharmacotherapy options that are available for obesity management in Canada. We'll talk about the considerations that we want to make in the use of pharmacotherapy. What helps us to choose which medication might be best for our patient? In what framework or context should we be thinking about pharmacotherapy? I'll go through some of the evidence that we collected from our literature review that have informed our key recommendations, which we'll go through one by one. We have also generated an algorithm, a pragmatic approach as far as how we should choose which pharmacotherapy might be best for our patient, and then we'll round out with the key messages from our chapter. In terms of the rationale for pharmacotherapy, we know that a modest and sustained weight loss is associated with improvements in comorbidities associated with obesity. So remember that treating obesity is about improving health. And we do know that that's about how much weight loss it takes in order to see substantial changes in weight. But I would also point out that as little as 1 kilo of weight loss in a patient with prediabetes actually reduces the risk of developing type 2 diabetes by about 16% per kilo. Health behavior change, which is what we traditionally think of as nutritional changes, physical activity, generally only achieves about a 3 to 5% weight loss, which can still be important. As we talked about, even a little bit of weight loss can benefit health. But the reality is that this is most often not sustainable over the long term. So the vast majority of people who do have some success with health behavior change end up regaining their weight and are not able to keep that success long term. Pharmacotherapy, therefore, should be considered to decrease weight and improve metabolic parameters and improve health when behavioral intervention alone has been ineffective, insufficient, or without sustained benefit. So I just want to put this in the context of the framework for the guidelines. And this is part of the patient journey in obesity management, which of course is surrounded by the 5 A's of obesity. That's the framework that we suggest going through. This is the third A, which is advising our patient on how they can achieve their health goals with weight management. So we see on the top left, we have medical nutrition therapy, which there's a separate chapter on that in the guidelines. On the right, we have physical activity. There's another chapter there as well. And these are the foci of the health behavior changes. Then we have the 3 pillars of obesity management that support medical nutrition therapy and physical activity. So we see on the bottom left, we have psychological intervention, which you heard about that chapter from Michael Vallis last week. We have pharmacological therapy, which we'll talk about today, and we have bariatric surgery. So with that framework now, let's talk more about pharmacologic therapy. The methodology for our chapter was that we generated research questions to inform on pharmacotherapy studies published since the last guidelines, which was 2006. So you can imagine that there was a huge number of articles that came our way over the last 14 years to generate our recommendations and messages. We opened our search to any prescription medication in Canada. So we know that there is a prescribing that happens sometimes for things like thyroid hormone or testosterone. And so we said, okay, let's keep our search open to include studies, if there are any, on those types of treatments. So that way we can inform and provide recommendations about whether or not these are appropriate treatments. We looked at randomized control trials of at least 6 months duration, and this was, of course, a systematic literature review. So let's now talk about pharmacotherapy and what we have available in Canada. So first of all, the indications for pharmacotherapy for chronic weight management is appropriate for individuals with a BMI of 30 or greater, or a BMI of 27 or greater with comorbidities associated with the excess adiposity. So this can be, for example, type 2 diabetes, hypertension, dyslipidemia, but isn't limited to those things. So pre-diabetes could be included here, polycystic ovary syndrome, sleep apnea, non-alcoholic fatty liver disease. These could all be considered to be comorbidities associated with the excess adiposity. There are 3 medications included and indicated for chronic obesity management in Canada. And remember, this is always in addition to the health behavior changes, in addition to medical nutrition therapy, and in addition to physical activity. These 3 medications are liraglutide 3 milligrams, which is the trade name Saxenda, naltrexone bupropion in a combination tablet, trade name Contrave, and orlistat, trade name Xenical. So now let's talk about the things that we should consider when we are wanting to use pharmacotherapy to help our patient with chronic weight management. So there's a number of things that we need to think about. What's the mechanism of action? How does this medication work? What are the potential side effects? What are tolerability issues or concerns that side effects that could happen that we need to talk with our patient about, that we need to think through with them? What are safety aspects? Are there any patient comorbidities for which those particular comorbidities would also be benefited by a particular medication choice? What are there other existing medications that our patient is taking? Are there any drug interactions that we need to think about? What is the mode of administration? Is it oral? Is it subcutaneous injection? How often is it needing to be given? And of course, the reality is cost considerations we need to take into consideration, as well as medical coverage and so forth that our patient may or may not have. I'm going to spend a little time now to go through several elements from one of the tables that we have in our chapter. So all of this is right in the chapter. So we just literally cut and pasted some of the elements from this table. And we'll go through each of the 3 medications. I'm going to kind of jump back and forth a little bit, so just bear with me here. So orlistat, first of all, which you see on the left, this is the first medication that was available of these 3 for obesity management in Canada, approved in 1999. This is an oral medication, and the way that it works is that it blocks fat absorption in the intestine. So if you eat a diet that's about 30% fat, it will block about 30% of that fat from being absorbed. An important point here is that orlistat does nothing for appetite. So every other medication available for obesity management helps to reduce appetite. Orlistat does nothing for appetite. It only blocks fat absorption. It's taken with meals at a dose of 120 milligrams 3 times a day. Liraglutide, which you'll see in the middle column at 3 milligrams, was approved in Canada about 5 years ago. This is a subcutaneous injection given once a day at a dose of 3 milligrams. And you actually increase that dose gradually over the course of at least a month in order to mitigate any, or ideally limit or avoid any potential GI side effects. And we'll talk about that in the next slide. We won't go there yet. So this again is a subcutaneous injection, and it works by reducing appetite in the brain. That's the primary mechanism of its efficacy. We then have naltrexone bupropion or Contrave in the far right. This is a oral formulation taken twice a day. You also titrate this medication up over the course of about a month, again to limit any side effects, which we'll talk about in a subsequent slide. If you take the full dose after you've titrated up, that dose then becomes 16 milligrams of naltrexone, 180 milligrams of bupropion twice daily. This medication also works by reducing appetite in the brain, and it also has evidence that it reduces cravings. So it affects that the wanting and liking of food as well. If we go down to the third line in this slide, this is the percentage placebo-subtracted weight loss. So we can see that orlistat is not overly effective in reducing weight. You get about 3% placebo-subtracted weight loss, though it can work for some people. Again, it doesn't reduce appetite. So when a patient loses weight, there is no mechanism in place with orlistat that helps to manage that appetite increase that happens when a person loses weight. Liraglutide and naltrexone bupropion both have about 5% placebo-subtracted weight loss. And just to point out, these are not head-to-head comparisons. These are all individual trials compared to placebo. One of Health Canada's approval recommendations for pharmacotherapy is wanting to know that a certain proportion of patients will achieve clinically significant weight loss, which is traditionally defined as 5%. So we've also included what proportion of patients achieve 5% or even 10% weight loss. And the message here is that there are many patients who can achieve clinically significant weight loss with these medications. And we see a range of weight loss results from person to person. So there is no one medication fits all in obesity medicine, just like there isn't in any other type of medicine. Different things will work for different people. And I really want to draw an emphasis now to the bottom of this slide, which is the effect on maintenance of previous lifestyle-induced weight loss. So both orlistat and liraglutide have evidence that they can help patients to keep weight off that they have lost previously with lifestyle changes. And this is actually a foundation for one of our probably one of our most important recommendations, because it's quite new, that we are recommending consideration of pharmacotherapy, not just for weight loss, but also to help patients keep weight off that they have lost previously. And this is very clinically relevant because, of course, a lot of patients will come to us and say, hey, I have done it again. I joined Weight Watchers. I lost 5% weight, but I'm really worried that I'm going to regain the weight because that is what has always happened to me. Can we do something to help to keep that weight off? And this is where we have the evidence for both liraglutide and orlistat that they can help to keep weight off that has previously been lost with lifestyle change. So remember that obesity management is about improving health. So I want to now go through some of the improvements in the cardiometabolic parameters that we see with obesity pharmacotherapy. So we had specific directed literature review questions about prediabetes and diabetes. So we see that there is evidence for both orlistat and liraglutide to prevent development of type 2 diabetes. So that's really, really important because we know that if we can help to nip the prediabetes in the bud and even revert it back to normal glucose tolerance, that is very powerful for improving that patient's health over time if we can prevent development of type 2 diabetes. If we go down to the bottom and we look at the effect of these medications in people who have type 2 diabetes, all three medications have been studied, and we do see a reduction in A1C with all of them. The A1C reduction we see with orlistat and naltrexone bupropion are probably mostly related to the weight loss that we see. With liraglutide, of course, we know that that is also a diabetes medication at the 1.8 milligram dose called Victoza. So it's perhaps not surprising to us that we see a greater benefit with liraglutide to reduce A1C with the anti-diabetes glucose lowering effects as well as the weight loss effects. And again, just a reminder, these are not head-to-head comparison trials. We also see that there's an improvement in cardiovascular parameters. So we see an improvement in blood pressure with orlistat and liraglutide. With naltrexone bupropion, with the weight loss, we actually do see a reduction in blood pressure, but initially there's a little bump up in the blood pressure because bupropion has adrenergic properties. So that's why the placebo-subtracted blood pressure change is actually a positive, not a negative. But with weight loss, we actually do see an improvement in blood pressure. But it is important that blood pressure is well controlled prior to starting naltrexone bupropion. We also had specific literature review questions in generation of this chapter with regards to fatty liver disease, polycystic ovary syndrome, osteoarthritis, and obstructive sleep apnea. So we have put specific information in our table as well. And as you can see, the theme is that there's not a lot of study on these health conditions at this point in time. We do see that liraglutide 3 milligrams has shown improvement in NASH, non-alcoholic steatohepatitis, this is a very important and very common complication of obesity. So it's really nice to see some data emerging in this area. Polycystic ovary syndrome, none of them have been studied with view to looking at improvement in menstrual cyclicity, though liraglutide 3 milligrams has shown weight loss in this group of patients. Osteoarthritis, not yet studied. Sleep apnea has been studied only with liraglutide, showing a reduction in the apnea-hypopnea index. Now, in terms of cost, these are medications that unfortunately are only covered by about 20% of private medical plans, and there's no public coverage at this time. And this is something that we in the obesity community are really working hard to advocate for better coverage, better access to pharmacotherapy. And we hope that the guidelines is a helpful thing for employers and public health agencies and so forth to inform in order to hopefully get more access. In terms of cost, if a patient is paying for it out of pocket, the cost is about $190 a month for orlistat, about $450 a month for liraglutide 3 milligrams, and about $300 a month for naltrexone bupropion. In the interest of time, I'm not going to go through all of this table in detail, but again, it's right in the guidelines. In terms of common side effects for orlistat, because it blocks fat absorption, it can cause loose stools and flatus because of the fat excretion that comes out in the stool. In terms of liraglutide, it transiently slows down the stomach. So because of that, it can cause nausea, constipation, diarrhea, heartburn, occasionally vomiting. This can be mitigated by increasing the dose more slowly. So it tends to be temporary, usually only for the first couple of months. If it happens in about 15% of people. And again, if you can slow down the dose escalation, if the patient is having those side effects, that can often be very helpful to mitigate that. Naltrexone bupropion has side effects which are already known from the individual components of these two medications. So Contrave itself has been available in Canada since 2018, but each of these medications has been around for over 20 years. And so nausea, constipation, headache, dry mouth, dizziness, diarrhea are the most common side effects. Again, you can try to increase the dose more slowly if the patient is experiencing any concerns to mitigate that. In terms of contraindications, pregnancy and breastfeeding are contraindications to all pharmacotherapy. And in the interest of time, I'm not going to go through each of those in detail, but if anyone has questions, we can certainly take those at the end. In terms of medication interactions, that's an important one, particularly with naltrexone bupropion, because it does have interactions with many other medications. So it's really important that you run through the other medications and search them up and make sure that there's no significant drug interactions, as you would with starting any pharmacotherapy for any medical condition. Okay, so the literature review that we just went through was what informed our recommendations. So let's go through those. Our first recommendation is that pharmacotherapy for weight loss can be used for individuals with a BMI over 30 or more, or a BMI of 27 or more with adiposity-related complications in conjunction with medical nutrition therapy, physical activity, and the psychological interventions, which is that pillar that you saw on the left side of that pillar picture that I showed you earlier. Pharmacotherapy may be used to maintain weight loss that has been achieved by health behavior changes and to prevent weight regain. So that's that really important recommendation. We want to move away from, we want to be thinking about the patient's context of where they came from in their weight journey prior to coming to us. When we're prescribing pharmacotherapy, if they've lost weight already, then further weight loss may not be the goal, but rather maintaining that weight may be the goal for that patient. So we want to individualize those goals in the context of the patient's weight journey prior to initiating pharmacotherapy. For people living with type 2 diabetes and a BMI of 27 or greater, pharmacotherapy can be used in conjunction with health behavior changes for weight loss and improvement in glycemic control, with evidence for all three pharmacotherapies for that recommendation. For people with prediabetes and overweight or obesity, we recommend pharmacotherapy in conjunction with health behavior change with BMI of 27 or greater to delay or prevent type 2 diabetes, with the evidence there at this time being for liraglutide and orlistat. We do not suggest the use of prescription or over-the-counter medications other than those approved for weight management. So coming back to what I discussed about our literature review process, that we open this literature review to all prescription medications, and none of the others had sufficient data to support their use for weight management. So thyroid hormone and testosterone and other prescription medications do not have sufficient evidence, so they should not be used. And in addition, over-the-counter supplements and so forth are actually reviewed in great detail in the commercial products chapter of the guidelines. So I would also refer you to that for further discussion there. And finally, for people living with overweight or obesity who require pharmacotherapy for other health conditions, we suggest choosing medications that are not associated with weight gain. So you'll see that recommendation and that theme echoed many times in many chapters in the guidelines. So antidepressant medications, anti-seizure medication, diabetes medications, antipsychotic medication. There's many medications that within those classes that can cause weight gain, but alternatives that actually can be weight neutral or weight negative. So any patient struggling with weight, we always want to be going to their list of medications to say, is there anything here we can optimize, anything that's working against them in their health journey that we can improve upon? So I'd now like to take you through our algorithm that we generated to help primary care in making a choice about, okay, I have this patient who's struggling with weight, I want to help them, I want to use a medication, how do I decide which one to consider? And this is really a pragmatic approach that we have developed. So we'll go through this. There's 2 slides here, and I'm going to jump a little bit back and forth between them. So bear with me on that. But again, this is right out of the guidelines chapter. So you can look at the whole picture if you want to call it the chapter and look at it at the same time. So starting at the top, so we have a patient who has a BMI of 30 or more or BMI of 27 with obesity-related comorbidity or comorbidities. So first thing we want to do is look at their medication list. Is there anything here that is having an adverse effect on their weight? Is there anything we can change here? Then we want to be thinking about the patient's comorbidities. So if we go to the left, is this a patient who has diabetes, prediabetes, hypertension, obstructive sleep apnea, polycystic ovary syndrome? If so, on the top left here, this is now continuing down in our algorithm. If a patient has any of those conditions based on the evidence that we've presented today, we may consider liraglutide as a first choice because there's evidence for improving these health-related comorbidities. Naltrexone bupropion could be a second choice, and orlistat again has less efficacy. It also does nothing for appetite, so we generally consider that a third choice medication. If we now go to the right here in our flowchart, what if this is a patient who really struggles with cravings? What if they are having some, they've got some blue mood or some depression issues that they're struggling with? What if they're a person who smokes and they're trying to quit? Going down to the next then. In those situations, we can consider naltrexone or naltrexone bupropion as a first choice medication because we know that it reduces cravings. We also know that bupropion individually as a medication is a medication that treats depression, can also be helpful for smoking cessation. So though that might be a way to marry the goals of helping that patient with their mood issue and their weight, or helping them to stop smoking and help them with their weight. And therefore, we have then listed naltrexone bupropion as a first choice to consider, followed by liraglutide, and then orlistat, lower efficacy, is third. Once we've chosen a pharmacotherapy, we then want to assess after at least 3 months on therapeutic dose. If that patient has not had sufficient success for weight management, then we can either think about stopping the medication if we think it hasn't helped at all, or if it's helped some but not enough, then we could consider keeping that medication on board and adding a second line agent. And I would just like to point out that there currently are no studies of combination pharmacotherapy that we can refer to here as far as using them together, but we recognize this is an evolving area, it's an evolving field, and we foresee that if we look a few years down the road, that we will see more studies of combination pharmacotherapy emerging. And if we look 10 or 15 years from now, I think we'll see what we have now in the diabetes world, where we have many different classes of medications and we use combinations depending on what works best for our patient. If we then just back to the algorithm here, after 3 months on therapeutic dose, if we find that this medication is successful for weight management, then we want to continue that medication long term. So remember that obesity medication does not cure obesity, it helps to control obesity. Just like a blood pressure medication doesn't cure hypertension, it controls it. A diabetes medication doesn't cure diabetes, it controls it. Obesity pharmacotherapy helps to control weight, helps to manage weight, and is intended as a long-term treatment. So again, pharmacotherapy is intended to be part of a long-term treatment. So here, just want to pause a minute here. And in the algorithm, we talked about deciding whether a medication was sufficiently successful for that patient's weight management. So we want to think about, have we helped in this patient's weight journey? Have we helped in improvement of health parameters? Most importantly, really important is that we want to think about the patient's previous weight trajectory, as we alluded to as well with our weight maintenance indication and recommendation for pharmacotherapy. So if you have a patient who's been saying, you know, I've been gaining 10 pounds a year for the last 5 years, my weight keeps going up, 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 and we start pharmacotherapy, we reevaluate, and they come back and say, you know what, my weight is actually stable for the first time in so many years. I haven't gained more weight. I would consider that a success of pharmacotherapy, and I would not stop the medication. So the traditional guidance is that a patient needs to lose at least 5% weight after 3 months on full dose, but we want to push the envelope on that and realize that that does not take into account the patient's previous weight trajectory. And the person who has lost weight with lifestyle change and now is able to avoid weight regain with pharmacotherapy, that too is a success of pharmacotherapy. If you have a patient that comes in and says, you know, yeah, I've had some success, but, you know, maybe you look at the weight has gone down by a couple of percent. Also think about what factors could be impeding the patient's weight loss efforts. Has another medication that been started perhaps that is actually contributing to weight regain? Is that patient struggling with mental health issues or emotional eating? And we actually need to address that in order to have success. And if we don't find any other etiologies and for the lack of success and we're having no success, then again, we can try stopping the medication, trying something else. Or if we feel like it has had some success, but perhaps not enough, then we could consider keeping that medication on board and then consider adding a second agent. So finally, our key messages. There are 3 medications indicated for chronic obesity management in Canada, in addition to health behavior change. That's liraglutide 3 milligrams, naltrexone bupropion in a combination tablet, and orlistat. All 3 medications have been shown to be effective in producing weight loss greater than placebo for a duration of at least 1 year in the clinical trials. Medications that are not approved as pharmacotherapy for obesity management should not be used for this purpose. And finally, the individual response to obesity management pharmacotherapy is heterogeneous. The response to medications can differ from patient to patient, just like any other health condition. In choosing the most appropriate obesity medication, we want to consider how it works, safety, potential side effects, tolerability issues, contraindications, drug interactions, mode of administration, and cost.
Wonderful. Thank you so much, Sue. my great pleasure to introduce our panelists for today. In addition to Dr. Pedersen and myself, we have Dr. Priya Manju, Dr. Sean Wharton, and Dr. Arya Sharma. Dr. Priya Manju is a specialist in internal medicine and endocrinology. She is a diplomate of the American Board of Obesity Medicine and a certified hypertension specialist. She is co-director of the Victoria Cardiometabolic Collaborative Clinic and chair of the Science Committee in Adult Clinical Committee of Obesity Canada. Dr. Manju has contributed to several national practice guidelines, most recently the Obesity CPG and the CCS Dyslipidemia Guidelines. She is on faculty at the University of British Columbia and the University of Victoria. Dr. Wharton, the third author on this chapter, has his doctorate in pharmacy and medicine. He is the medical director of the Wharton Medical Clinic, a community-based internal medicine, weight management, and diabetes clinic. He is an adjunct professor at McMaster University in Hamilton and York University in Toronto. He also works as an internist at Women's College Hospital and the Hamilton Health Sciences. Dr. Wharton is a researcher and is qualified as a diplomate of the American Board of Obesity Medicine. Dr. Wharton's research focuses on bariatric medicine and type 2 diabetes. He is the co-chair of the Canadian Obesity Guidelines. Dr. Sharma was recruited from Berlin, Germany in 2002 to a Canada Research Chair in Cardiovascular Obesity Medicine at McMaster University. In 2007, he accepted a position as professor and chair in obesity research and management at the University of Alberta, where he's also the medical co-director of the Alberta Health Services Provincial Obesity Program. In 2005, he spearheaded the launch of the Canadian Obesity Network, now Obesity Canada, which has remarkably transformed the landscape of obesity research and management in Canada. His research focuses on an evidence-based approach to managing patients living with obesity and includes the development of the Edmonton Obesity Staging System. So we have a number of questions, and thanks so much for upvoting them. So I think we'll lead off with Stephen Teo. He was wondering about using liraglutide in women with obesity who may become pregnant on treatment, and also had some questions with regards to obesity with other comorbidities. In this case, he was highlighting end-stage renal failure due to polycystic kidney disease. Would anybody like to tackle some of these other aspects of use of liraglutide?
Sure. So maybe I'll start with the pregnancy question, and then maybe someone else wants to take the other part of that question, or the reverse is fine. So as far as pregnancy, there is no safety evidence for any pharmacotherapy in pregnancy or breastfeeding. So we want to also make sure that any pharmacotherapy for obesity is stopped prior to any conception attempts. There's no data to inform us on exactly how long should it be stopped prior to conception attempts. We often say 6 weeks, just to make sure that whatever they're on is completely out of their system. If I understood that correctly, that patient had gotten pregnant while taking liraglutide 3 milligrams. So as soon as, if that patient were to call me and say, oh, hey, I'm on Saxenda and I got pregnant, I'd say, okay, well, stop liraglutide. And then there's really nothing more to do from there. There's no evidence of any known harm of liraglutide in patients who do become pregnant on it. But certainly we want to be educating our patients who are on pharmacotherapy and are of reproductive potential that they need to stop it 6 weeks prior to any attempts to get pregnant. If this was a patient who had pre-diabetes or type 2 diabetes, we also have to watch the sugars very closely, because when they stop the liraglutide, being also a diabetes medication, sugars could, of course, go up. So we need to be watchful for that.
Super, thanks, Sue. Anyone have any thoughts with regards to really complex tertiary patient that Stephen was sharing with us around, who had underlying end-stage renal failure and difficulties with treatment due to excess adiposity? Arya, how would you tackle that?
Well, I wouldn't have any primary concern. I mean, there's not a lot of evidence of the use of these compounds in people with end-stage renal failure. But even with progressive renal failure, I think if anything, uh, I would see this as somewhat protective actually, because, there's, if you're talking about liraglutide here, it does have a, mild blood pressure lowering effect and maybe other metabolic benefits. So I wouldn't primarily be concerned. I also don't think that you need a dose adjustment. Um, but there's very little published literature on this.
Mhm. Perfect, thanks.
Yeah, I
And
can
there's a
comment. Sean here, I can comment on it as well. We've been using liraglutide and GLP-1 analogs in patients with going into end-stage renal failure and with eGFRs lower than 20 in concert with the nephrologist. So it's great that Arya spoke up. So if you're working with the nephrologist and together you know that there's no toxicity, you're monitoring everything, then it works out really well. It would be the only one out of the list that we currently have right now. I would only use the GLP-1 analogs, even though once weekly we've actually been using in these end-stage renal failure patients with the help of the nephrologist.
Mhm. Thanks, Sean. So Imad and Stephen are asking us both about duration of therapy. And so how long would you maintain patients on these medications? Are there circumstances when you would recommend stopping them?
Priya, do you want to take that one?
Yeah, sure. I think that all of the studies do show that when patients stop the medications, they do regain weight. And I think patients have to recognize, or one of the things I share with patients is the management of weight is a long-term process. It's hard to say to a patient, you're going to be on this medication for the rest of your life. And that's not usually the approach that I take. But I certainly share that there are times where medication is going to be more helpful to them, times when they need that support to maintain the healthy behaviors. And so one of the things I sort of say to patients is, let's see how you do on the medication first. When you get to a point that you feel that you're able to sustain these behaviors and these changes, there aren't a lot of external pressures, we can try weaning it down a little bit and see how you do. And really, it's a discussion with patients in terms of the duration of therapy. So that's been my approach. I also tell patients that another approach would be intermittent therapy throughout your life. But most of my patients who've been on therapy and have had success on therapy feel that it's a lot easier to maintain the focus on healthy behaviors, which is essentially what we're trying to do with pharmacotherapy. And most of them do not want to stop. Some do have to stop because of financial concerns. And in that situation, there are a couple of strategies that I use in terms of helping with samples or doing lowering the dose so that the medication can go a little bit further.
Arya here, so just in terms of intermittent treatment, it's important. I mean, patients often start and stop medication. Yep. They do it with pretty much any medication. I think all you have to really tell them is that when you stop the medication, at least for a week or longer, you might not want to start with the last dose you are on. Yep. You want to up-titrate again, because otherwise you just get the side effects. And that's happened quite a bit. So it's also a question when you have a patient who's been tolerating the medication quite well, and then suddenly, after they've been on it for 2 or 3 months, suddenly start complaining of side effects. Mm-hmm. You need to ask whether they're actually taking it regularly, because what I've seen people do is that, when they think they've reached a stable weight, they actually start increasing the intervals between doses. They don't take it every day, and then the side effects start coming back.
I would also add to that sometimes patients will say they're nervous about damage to their metabolism or damage to their health somehow if they are to take it for a while and then they stop it. Like maybe they're afraid that, well, I don't know if my drug plan is going to last for the rest of my life. So if I start this, what's going to happen if I stop? So it's important that patients understand that it's not doing any damage to them if, let's say, they take it for a couple of years and they have good weight management success. then they unfortunately lose their job and their drug plan. And if they're not able to afford it, the weight probably will go back up, because as Priya said, that's what we see clinically and in the clinical trials as well, but it's not doing any damage to them to do that. And the other thing I would add also is that over time, as obesity pharmacotherapy evolves, I think it will be more about changing medication rather than, how long do I take this? Do I take it for the rest of my life? Well, probably no, because probably as time goes on, we expect to see new pharmacotherapies. Actually, probably in the very near future, we'll see new treatment options and combination treatment options, where it's actually about changing the approach to evolve with updated options for pharmacotherapy.
Yeah.
Mm-hmm. Super, thanks, guys. So there's a couple questions here around, that we all have made a strong point in these guidelines that the outcome isn't weight, it's health. However, the point we're making here is that there are medical conditions where the excess adiposity is contributing to harm, to physical and metabolic harm for the person. And the point is being made that the weight loss can be highly variable from person to person. Mm-hmm. And some people may, realize other benefits regardless of the weight loss. And so people are wondering about broadening out the outcome measures in some of these pharmacotherapy studies beyond weight. And maybe someone can comment on what's happening in that space.
Yeah, I'd like to start with this question, if that's okay. I think as we start using more of these agents to help patients achieve their weight management goals, you'll find some patients who say, well, this medication, I'm not losing as much weight as I thought I did, but it's so much easier to remain focused on the healthy behaviors. And I think that makes things less of a struggle for the patient. And so that's one of the things that I consider very strongly when using a medication. It's not just, weight management is what this medication is approved for, but we have to have, as Sue outlined in the presentation, appreciation of how that medication can affect different facets of the patient's life. So controlling craving may be better. It may have more of an effect on their diabetes management. For example, with the GLP-1 analogs, there are some studies that are open label studies that look at other parameters of well-being with Contrave. Those are open label studies, and they're not the highest quality evidence, but I think we'll start seeing more and more of those types of studies coming out, looking at different aspects of behavior and the effect of the medications on behaviors that are important to weight management.
Mm-hmm.
And as we move on in pharmacotherapy research, we also now are putting much more focus on studies looking at comorbidities. So what about this medication and its benefit in osteoarthritis, for example, or patients with obstructive sleep apnea that's not well treated. So there's really a movement in the obesity pharmacotherapy clinical trial world, moving into having more focus on the health-related comorbidities. We still look at weight, of course, but we also really are having major focus on, okay, what percentage of patients with prediabetes revert to normal glucose tolerance, and questions like that.
Okay, great. So we have some questions here, related questions around people living with type 1 diabetes and obesity. So, perhaps if there's different medication experiences for that group of patients. And questions as well about timing of the medication and other medications that approved more for type 2 diabetes, such as Ozempic. Do you want to comment, given your background with diabetes, Sue, on how you might approach this in type 1 diabetes, and then your medication choices for people with type 2 diabetes in this space?
Sure. So for type 1 diabetes, unfortunately, there is really no clinical trials for patients with type 1 diabetes who are also living with overweight or obesity with regards to weight management pharmacotherapy. It's definitely a gap in the literature that needs to be addressed. There's lots of people with type 1 diabetes who struggle with weight, just like the majority of Canadian adults without diabetes also struggle with weight. There is a little bit of data with liraglutide at the diabetes treatment dose, so for Victoza in type 1 diabetes, showing some reduction in weight. There can be an increased risk of hypoglycemia because insulins need to be adjusted appropriately, and a small increased risk of diabetic ketoacidosis, which is probably not related to the medication so much as just medication, insulin adjustments needing to be done appropriately. There is no data for Contrave or Listat in type 1 diabetes. So, and then the type 2 diabetes question. So there are, as we already went through, the data in patients with type 2 diabetes for all of these obesity medications. There is also, of course, medications for type 2 diabetes that are not approved pharmacotherapy for obesity, at least not at this time. And of course, the one that comes to mind is semaglutide, which is Ozempic, at the dose of 1 milligram once weekly. And this medication seems to be, based on what we know and very much evolving literature, that this medication is an excellent medication for weight management in addition to diabetes treatment. It is not yet is not yet approved anywhere as a weight loss treatment or an obesity pharmacotherapy, but it is being studied at actually a higher dose than the diabetes treatment dose. Diabetes treatment dose is 1 milligram once weekly. The obesity pharmacotherapy dose is higher than that. And at this point in time, there are 4 key trials which have had high-level reports showing very impressive weight loss in the weight management trials, but they are not yet published and it is not yet approved. In addition, there are also SGLT2 inhibitors, which is type 2 diabetes treatment, of course, and now also has indications for treatment of heart failure. And we'll also see, we also have good data for renal protection now, even in people without type 2 diabetes with dapagliflozin, which just came out. And these are weight negative medications as well. So these are medications that can also be beneficial to help that patient with type 2 diabetes with weight management. And now those indications are broadening beyond type 2 diabetes as well.
Yeah. Just to clarify, with weight negatives, Sue, there you mean the weight will go down, not that they're adverse.
No, weight, yes, correct. Weight will go down.
Okay. Just to clarify.
I'd just like to sort of add, just in regards to patients with type 1 diabetes who are living with obesity, it wouldn't be incorrect to have a discussion with them about trying weight loss medications. One would just have to be very careful in those patients to monitor for hypoglycemia and also to be very cautious about the risks that Sue mentioned, particularly DKA, which again, the medications themselves don't cause, but by reducing the amount of insulin that the patient is taking, you might inadvertently trigger that. So, I think a discussion with the patient is very reasonable. Set expectations, choose the patient that you're going to use these medications in very carefully, and balance the values and preferences of that patient in the context of the potential side effects. But I think those patients would certainly benefit from weight loss medications. Unfortunately, we don't have a lot of data in that area yet. But I think it could be done with careful monitoring.
Yeah, and I agree with Priya on that absolutely as well. And just to make sure that everyone here understands that that's off-label, of course, because there's not any data.
Yep. Yeah. So those are really tertiary questions at this point. And so super, thanks for the details. And actually, there's another really important, I think, tertiary question here, which is in people who are taking these medications for chronic condition of obesity, if they're admitted to hospital with different presentations, would there be times where it would be really important to hold the medications, or how would you recommend managing these medications in the inpatient setting?
Sean, do you want to take that one?
Yeah, so this is Sean here, right? So I have seen that a number of patients have stopped their medications when they've gone into the hospital, and I don't see it as a necessary step. This is not an SGLT2 inhibitor when we're talking about the GLP-1 analogs. I don't even think, contrary, if they're not in hospital for something that is specific to the medication, i.e. Excessive nausea and vomiting, where there's a dehydration setting, or there is a pancreatitis setting, abdominal pain, abdominal issues, then those are conditions where you would actually stop the medication. Otherwise, if they're in hospital for other reasons that don't have to do with the medication, I think there's a question there about a open fracture. So I would be careful with the GLP-1 analogs if the dietary interventions have changed, and with the patient if they're not taking things orally for a period of time, stopping the medication for surgery would be necessary, like any other hypoglycemic agent that could potentially cause hypoglycemia, although this typically doesn't. But if they're on very, very low amounts of calories, that would be the issue there. So normally I would not stop them for the majority of cases, but I would in certain cases be that clinical doctor in the hospital and make the appropriate call.
Yeah, right. Another question, guys, just so many good questions here. When we talk about yo-yo dieting, and Arya, you've certainly talked about this a lot, and sort of the adverse effect on people in terms of their basal metabolic rate. Kimberly is asking whether or not there's any adverse effects from pausing these medications and restarting them. Will that reduce the effectiveness the next time that they take the medication? I don't know the answer to that, so I'm hoping one of you guys does.
Arya, do you want to take that one?
Sorry, I was distracted. Just go ahead.
Yeah, just we're talking about yo-yoing and the risks of yo-yoing in terms of impact on basal metabolic rate and people's challenges with future weight loss. And Kimberly's asking the question about in the case of medications,
Sure.
if people take medications and then
always,
take breaks.
Sure. Yeah, there's always a risk that you get metabolic adaptation anytime you lose weight. Now, there's not a lot of literature on how long it lasts and how severe it is, and there's certainly a lot of individual variability in how much people adapt. So again, it's something you want to be concerned about or monitor carefully. I wouldn't go as far as to advise that people actually measure metabolic rates, but it's certainly one of those things that one needs to be cautious about. We do know it happens with extreme weight cycling. So if you remember the people from The Biggest Loser who lost really enormous amounts of weight, there was no doubt that there was I won't say a lasting effect, but there was certainly seemed to be a long-term effect on metabolic adaptation. Whether smaller changes in body weights would have the same effect and whether that effect would last long or over time is really not clear.
Mm-hmm.
I think
the final, sorry, I'm just mindful of time because we do want to wind up in a couple minutes, but I just wanted to, Barb's been patient and has had her question at the top of the list for a while, just around coverage, because this is such a barrier to patients, and there has been such work at Obesity Canada around trying to advocate for this. Can anyone give us a little bit of a summary about health plans which cover or work that's going on with regards to advocacy for coverage?
Yeah, this is a moving target, of course, but as it stands right now, about 20% of private medical plans cover obesity pharmacotherapy, meaning of course 80% do not. So there's a major gap there, and there's no public reimbursement. So we, as you said, Denise, we really hope that these guidelines can serve as an important advocacy tool in order to improve access. Imagine not having the same situation in the diabetes world or the hypertension world. That would be unacceptable. So why should that be any different for this chronic medical condition?
Excellent. Okay, well, I'm mindful that we're getting to the close, and thanks everyone so much for your questions. There are a number of questions here that get into some of the other topics that would be great for the Timed Right group. So I encourage you to join that group and carry on with these conversations between sessions. I really want to thank all of our attendees today, as well as all of our panelists and Sue particularly for a great presentation. All the guideline authors, especially for this pharmacotherapy chapter, which really is so very important. So we really appreciate your feedback for these sessions. So there's a form that's up on your screen right now with a link or a QR code. Please give us your feedback and let us know how we are addressing your questions. I'm glad that we triaged to make a separate bariatric surgery session, because obviously this was a rich and full session to the last minute today. So thanks so much to everyone for your interest, and look forward to seeing you online on the Time Break community. Thank you so much, Sue. So on the panel this evening, in addition to Dr. Pedersen and myself, we have Dr. Priya Manju, Dr. Sean Wharton, and Dr. Arya Sharma. Dr. Priya Manju is a specialist in internal medicine and endocrinology. She's a diplomate of the American Board of Obesity Medicine and a certified hypertension specialist. She's co-director of the Victoria Cardiometabolic Collaborative Clinic and chair of the Science Committee and Adult Clinical Committee of Obesity Canada. Dr. Manju has contributed to several national practice guidelines, most recently the Obesity Clinical Practice Guidelines and the CCS Dyslipidemia Guidelines. She's on faculty at the University of British Columbia and the University of Victoria. Dr. Wharton has his doctorate in pharmacy and medicine. He's the medical director of the Wharton Medical Clinic, a community-based internal medicine, weight management, and diabetes clinic. He is an adjunct professor at McMaster University in Hamilton and York University in Toronto. He also works as an internist at Women's College Hospital in the Hamilton Health Sciences. Dr. Wharton is a researcher and is qualified as a diplomate of the American Board of Obesity Medicine. Dr. Wharton's research focuses on bariatric medicine and type 2 diabetes. He is the co-chair of the Canadian Obesity Guidelines. Dr. Sharma was recruited from the Humboldt University in Berlin, Germany in 2002 to a Canada Research Chair Tier 1 in Cardiovascular Obesity and Management at McMaster University. In 2007, he accepted a position as professor and chair in obesity research and management at the University of Alberta, where he is also the medical co-director of Alberta Health Services Provincial Obesity Program. In 2005, he spearheaded the launch of the Canadian Obesity Network, now Obesity Canada, which has remarkably transformed the landscape of obesity research and management in Canada. His research focuses on an evidence-based approach to managing patients living with obesity and includes the development of the Edmonton Obesity Staging System. So welcome everyone, and thank you to everyone attending this evening. I'm excited to see that the Q&A session is starting to heat right up, so please upvote the questions you want answered and type in your questions. And Julius is kicking us off and asking about whether or not pharmacotherapy is a lifelong commitment and whether there's any evidence that the arcuate nucleus located weight set point can be reset after maintaining a lower weight over time. So who on our panel wants to kick us off with that? Sean?
Yes. Hello. Hi. This is Sean Wharton here. Thank you. Terrific question. And I'm going to answer it in a very succinct manner so we can get on to a lot of the other great questions. So this is a very unfortunate answer. There is no evidence that the arcuate nucleus gets better. There's no evidence that the set point gets better. So when we think of weight management, you have to think of it as if the patient gets the weight down and the weight is staying down, that's because they're keeping their foot on the gas. That you take your foot off of the gas, which is any behavioral intervention that you're doing, any one of those three pillars that you happen to be doing, things will go back to previous because the arcuate nucleus and the scar tissue and the hormonal changes never change. So they always want to go back to the previous weight. So the only way you're keeping the weight off is by keeping your foot on the actual gas. So that sometimes means going from one pillar to another pillar. Sometimes you're on the pharmacotherapy pillar, then you introduce the psychological pillar, or you use both of them together, or you flip to bariatric surgery. And the reason we have to use all of them all the time interchangeably is because of this point, that it doesn't go back to normal and the hormones keep on raging.
Priya, did you want to chime in on that one?
Yes, I think Sean described it really very, very nicely. And I think sharing that with your patient, sharing to them that it's not obesity is a chronic disease. It is not a disease of volition. It has a real neurobiology that sort of makes it very hard to lose weight. Really, the definition of survival is to achieve and maintain your highest weight. And unfortunately, our environments have changed, and the arcuate nucleus doesn't function as well in this environment as it did when food sources, etc., were less available. I mean, that's a very simplistic way of describing it, but I think the goal of pharmacotherapy is to, as Sean put it, make it easier for patients to keep the foot on the gas, to keep those healthy behaviors going despite the pull and tugs of pharmacotherapy. And, there is I myself have often wondered about this. There is no evidence that this set point can change, but I do sort of wonder about plasticity of the brain. And again, in younger patients, I'm always a little bit more aggressive in trying to get that weight down in a younger person. Because one of the things we have to remember is that at whatever weight you attempt weight loss and you attempt healthy behavior change, there is a limit on how low you can go. So it on average, it's about 5 to 15%. Some people are, as Sean calls them, winners, and they can go further. But if you start this process at 220 pounds, we're looking at 5 to 15%. If you started at 300 pounds, you're looking at 5 to 15%. So the sooner we engage people in this process, the easier it is to sort of achieve a lower weight. Sean, what do you think about that?
Yeah, I really like the way you stated that. It is that much. So the higher they start at, the less chance you'll get to getting to, let's say, a quote unquote reasonable weight or weight that a person may want to actually be at. So starting early is important, and and we really know that. So we shouldn't wait until their 60s and their 70s. We're looking at adolescence, starting really early because it's important.
We know also that there is an inflammatory process that happens in the hypothalamus, which is the appetite regulating center, the fundamental basal regulation of weight in our brain. And the longer you have obesity, the more you have this inflammatory process that can lead to essentially scarring of that area and causes that hypothalamus to not function properly, which is part of the what defines that new set point. So it also maybe helps us to understand why, if someone has something in their life where they gain some weight really quickly and temporarily, like due to a new, like let's say they're on prednisone or in pregnancy or something like that, that it may be easier to lose that weight that has only been present for the short term because it hasn't had that chronic inflammatory fibrotic effect yet. So I completely agree with Sean and Priya that we want to intervene earlier. We want to do what we can to help patients get weight down before that trajectory goes up and up and up and persists over the long term, because the longer it goes on and the higher the weight, the harder it is to have successful weight management. Doesn't mean we can't, but it does make it more challenging the longer it's gone on.
Mm-hmm. Super. So we have some questions here about sort of emerging therapeutics, and I would highlight to all the webinar attendees that there is a section in the therapeutics chapter on emerging therapies. We are very careful with the CPG to only endorse things that actually have robust evidence, but with that as a caveat, Nicole and Teresa are asking about the status of clinical trials related to semaglutide. And perhaps clinical experience with that, perhaps in your patients with type 2 diabetes. Priya, did you want to take a stab at that one?
Sure. I think I do know that there have been very promising studies showing the benefits of semaglutide in the for the role of weight management specifically. I personally feel that there is a lot of off-label use, and I think as long as we can't advocate off-label use, But I think if you're going to do that and you have a discussion with the patient that this is off-label, we're not there yet in terms of approval for weight management, but those trials are definitely coming. If you have an informed discussion with the patient and you document that they've been told it's an off-label use, they're okay with that, then I think that's a reasonable thing. That's a reasonable approach. Again, you may not get coverage for it. There is no behavioral program or patient support programs that are associated with drugs that are approved for weight management. So Saxenda or liraglutide has a patient support program. Contrave has a patient support program. So I think those are just some of the things to consider, but certainly, semaglutide is cheaper. So it's certainly, I have myself had to do that in the best interest of my patient, but I have discussions about that with them. Sue, I think, is involved in some of the trials of semaglutide. I think Sean is as well, and maybe I'll have them chime in.
Sure. Yeah. So the STEP program is the phase 3 clinical program for semaglutide as an obesity treatment, and it will be at a higher dose than what we're familiar with for type 2 diabetes. So for type 2 diabetes, the dose of Ozempic is a maximum of 1 milligram weekly. Semaglutide for obesity will be 2.4 milligrams weekly. The 4 key clinical trials from that STEP program have been completed. They're not yet published. We're working on publication and writing them up right now. But the data that has been released to the public is that in some of the trials, they've seen 16 to 18% weight loss at that dose. So quite impressive versus about 6% on placebo. So this is certainly the medication that is the next closest to becoming the next approved obesity medication. But I agree with Priya, in our patients with type 2 diabetes, where we use it very regularly on label, we see really nice weight loss results in the vast majority of patients.
Super, thank you so much. And so that's a good segue into Jody's question, who's talking about the struggles with getting coverage for these medications and to make treatment more accessible. And Arya, I'm wondering if you want to comment on the work that Obesity Canada has been spearheading in that direction.
Well, this is of course a big issue for for Canadians living with obesity. And the last report card published by Obesity Canada last year, it was clear that only about 20% of people of Canadians have access to these medications, and all of those are through private benefit plans. And not even all private benefit plans cover obesity medications. So this really is an issue. Currently, none of these medications, perhaps with the exception of Orlistat, are on any of the public formularies. And so that makes access really, really difficult. Now, in terms of advocacy, our own experience has been that sometimes when patients, write a lot of letters, make phone calls to speak to supervisors, etc., sometimes letters of support from the physician can help. Not always, but we always advise that patients, directly contact, their benefit provider, and we've seen exceptions made. So there are certain professional categories that appear to have really good coverage in some provinces. So in the province of Alberta, for example, all of the nurses have coverage, all of the teachers have coverage, the RCMP has coverage, the city police does not. So, there are wide swaths of, professionals who do have coverage through their plans, but it's very sketchy, and, it continues to be that most Canadians don't have access to these medications.
Thanks, Arya. Yeah, there's a great question here from Carfu about the use of pharmacotherapy in people who have had bariatric surgery, as well as a two-part question also around the use of this in people who are older and sort of taking into account sarcopenic obesity in the application of these medications. Sean, do you want to take a stab at that?
So great. So in terms of patients post-bariatric surgery, so Arya Sharma has written an article, and I've written an article on it where we looked at research patients who have presented to our clinic post-bariatric surgery who have gained weight. We looked at them before liraglutide, the first medication really to come out after Xenical, to see what type of weight loss we could get when we just implemented them to eat a little bit better, go on a diet, try to do the behavioral changes. At that stage, what they did was they gained 0.5 kilos. So they stopped gaining weight and they kind of maintained. So that was good. But then when we got the introduction of medication, they actually lost 6 kilos. So we went from just maintaining to losing weight. And every single other clinical evidence in ARIA's series of patients, there's other ones in other countries showing that the introduction of pharmacotherapy post-bariatric surgery after patients have regained weight shows a positive impact. It's not usually as great as we get with the patients who have not had previous bariatric surgery, where we should get about 10% weight loss or so. Here we're getting about 6 kilos, about 6% weight loss, maybe 7. So it isn't bad, and it's much better than them continually gaining weight. When it comes to the elderly, the majority of our patients that come to our clinic are actually elderly, and the majority of patients in many clinical trials are quote unquote older than 60 or in the 50s to 60s to 70. So patients do very well on pharmacotherapy. Many of these patients have elevated weight the same way a 35-year-old or 45-year-old does. So they're no different. Now, when it comes to sarcopenia or problems, because then that would not be something, if they're having a medical problem because they are older, because they have cancer, because there's other things going on, then that's not the time to use the medication. If their adiposity is causing a medical condition, then we use it. And to battle some of the sarcopenia, I would recommend, of course, doing resistance training, which for a lot of elderly people they need to do.
Yeah. This is Priya here, just to chime in there. I think when you're also, as Sean rightly said, you have to look at, when you're looking at obesity pharmacotherapy, you always have to weigh the risks and benefits. So if your patient has a compelling, even if that is an elderly patient who has a compelling reason for reducing weight, and there are certain situations, whether it be related to musculoskeletal issues or benign intracranial hypertension or their overall metabolic risk, then you really do have to take that into consideration. If there is another reason why they're losing weight, then you also have to sort of put that into context. Like if the person does have cancer, and there is weight loss for another reason, you have to sort of decide if putting them on pharmacotherapy is important. But in and of itself, when you do lose weight, you do lose some muscle, and there are some things that you can do to maintain that muscle. So physical activity is important. For example, making sure in the elderly that they're getting enough protein to maintain and having adequate nutrition, as well as physical activity to maintain the muscle mass, are some of the things that you can do to offset that sarcopenia.
Mm-hmm. Thank you, Priya. I just wondering if anybody has any other things to comment on that, or we'll pivot to the question about binge eating disorder. Okay, Sue, do you want to just comment on your experience with treatment with binge eating disorder? So Julius is bringing that up, which is really excellent because we haven't really discussed it, and is wondering also about whether there could be broader application of some of the medications used for that condition in other patients living with obesity.
Yeah, so I see the question is whether some of the weight loss from binge eating disorder treatments is through just appetites. Is it appetite suppression? Is it treating the impulsivity aspect? And it's I'm sure it's both. And actually, Vyvanse for binge eating disorder actually also has it has an indication for treatment of binge eating disorder, and is also can be very effective to help those patients lose weight as well because of the adrenergic properties as well.
Mm-hmm. And so is there anything where it's, yeah, thanks, Arya.
Yeah. So the importance of recognizing impulsivity, and it's not just binge eating disorder; it's also attention deficit disorder. So these patients have problems with impulse control, and it's really extremely difficult for these patients to follow meal plans, to plan meals, to keep food diaries, to that's just part of their situation, and that's where we find that medications that are indicated for attention deficit disorder, or in the more specific case, as was mentioned, Vyvanse for the specific indication of binge eating disorder, is extremely helpful. Not so much because these medications actually cause weight loss, but because they allow patients to do the things that they need to be doing. So in the same way, so I look at a lot of these medications similar as I look to the depression medications. If you have a patient who's got severe depression, you're not going to get anywhere in terms of weight management, because someone who has depression is simply doesn't have the motivation, doesn't have the energy, doesn't have the focus, to do all the things that would be necessary to actually, make those lifestyle changes, take the medication, and show the initiative. So you have to treat the depression first in order to actually make progress here. And I think when you talk about someone with binge eating disorder or ADHD, it's a similar situation. You have to kind of treat that condition first, so that a patient can then do what is necessary to better control their obesity.
Thanks, Arya. Priya, did you want to chime in on that one?
Just to say that often binge eating disorders are associated with other behavioral diagnoses, so specific psychiatric diagnoses, and screening that patient for depression, getting mental health professional involved to help you as needed is important. It's not just a matter of treating it with a drug. I think the drug is one part of it, but there's a lot of other aspects of the disease process that has to be considered, and management. So it's one of those again, it highlights the importance of a multidisciplinary approach.
Thanks, Priya. That's a great note to end on. So for Leslie, he's got a great question here, just around practicalities in your experience with treating patients with obesity with pharmacotherapy, and what kind of side effects and intolerances you may be experiencing and how you work around it. So specifically was wondering about how often you might find patients intolerant to the liraglutide at 3 milligrams subcutaneously. So Sue, do you want to chime in on Lindsay's question?
So for both liraglutide and Contrave, so Saxenda and Contrave, both of them are titratable medications, and for both of them, the recommendation for titration gets you to the therapeutic full dose after about a month. So both of them, you increase the dose usually by once a week until you get to the full dose. Most people tolerate those rates of titration very well without any problems, but sometimes people will experience, so the question here is for liraglutide, so we'll focus on that. Some people experience some gastrointestinal side effects because liraglutide transiently slows gastric emptying, which is a transient phenomenon that usually goes away after a patient has been on medication for a couple of months. So if a person is struggling with those kinds of side effects, I would suggest a few things. One is you can slow the rate of titration. It's not a sprint, it's a marathon. So some people will take a few months to get up to the full dose. That's totally okay. So we can back off if they get to, let's say, 1.8 milligrams, which is the third titration step. Oh no, I don't feel so good. Okay, go back to 1.2. We'll do that for a little longer. You can even count up clicks between doses on the pen and work your way up even more slowly. The second thing that I recommend is looking at the dietary pattern. Avoiding spicy food during the titration phase anecdotally can help. Making sure that the meals are smaller, because sometimes it's that habitual process that a person has of, this is how much food I should be eating, this is how big my breakfast is, this is how big my lunch is, this is how it's been their whole adult life, and now their body is telling them, stop, I don't want this much food, but the habitual nature of it, maybe they try to keep eating that and then they don't feel good. So smaller meals. And also lower fat during the titration phase can help to mitigate some of those side effects. And with all of those strategies, most people will tolerate the full dose.
Super, thanks, Sue. Arya, did you want to chime in on that?
No, that was a pretty comprehensive answer.
Okay, great. Well, then our last question is from Marie Claude, who's wondering about with binge eating disorder, whether you might do a combination of psychostimulant plus weight loss medication, is wondering about Contrave together with Vyvanse. Is that something that anybody's ever tried before? Certainly, I'm sure there's no studies about it, but.
Yeah, Sean Morton here. Sean, yeah, I would be a little hesitant with Vyvanse and Contrave as a combination. We know that Contrave does have a lot of interactions with a number of medications. Does it have an interaction with Vyvanse? I actually looked it up once recently, and it said no, that there wasn't really a interaction with Vyvanse. But we do know that you're dealing with when we look at the bupropion component, there's an adrenergic component to it, which is why the bupropion is usually called a booster. So you have an antidepressant that usually works like Cipralex or something, and you put and the person's mood isn't quite high enough. So you give them this adrenergic agent, norepinephrine, dopamine reuptake inhibitor, and it ends up boosting things a little bit. So you combine that with Vyvanse, I don't know where things are going to go. So sometimes what I is combine Vyvanse with the GLP-1 analogs, and because there's not an interaction that I am aware of that would cause a problem. That's what I tend to do.
Yeah, and I think just to add to that, I think again, as Sean highlighted, with bupropion, there are interactions with the cytochrome P450 system. So the drug is both metabolized by and affects other CYP systems in the liver. I think what Sean mentioned about the excitability and of having two neurostimulants, I would worry a little bit about increasing the seizure potential as well, because both bupropion and bupropion can lower that seizure threshold a bit. So one of the contraindications is patients who have a history of seizures, and Vyvanse can do the similar thing. So that would be one of the concerns. I think I would, in that situation, opt for, as Sean said, using a GLP-1 analog.
Super. Well, thanks so much to all of our panelists, and especially Sue for the wonderful presentation, and to all of the attendees participating today. I really encourage you to join the Timed Right community, where there's lots of opportunity to have further dialogue between webinars. It's getting very dynamic, lots of things going on. So please sign in and check that out. And also, we really do appreciate your feedback. So if you could provide us some feedback and perhaps some experiential evidence from your own clinical practice in our QR code, that would be tremendous as well.